Assalamu alaikum wa rahmatullah. Good evening, everyone. I would like to welcome you all to our final lecture for this month in our series of online lectures throughout the month of October, which were run by Nafs Initiative under supervision of the Psychiatry Department at King Fahd University Hospital in Imam Abdurrahman bin Faisal University. It's a great pleasure for me to introduce our guest today, Dr. Yasser al who will be presenting today's lecture titled, Is It Important to Know Why? This lecture tackles a common category error in psychiatric diagnoses, which would be a topic of interest for practitioners in healthcare and specifically in the field of mental health, as it allows us to better understand our patients and enhance the care we provide. Dr. Dabbagh is a child and adolescent psychiatrist, psychoanalyst, and a neuroscience and mental health researcher at King Fahd Specialist Hospital in Dammam. He has been also a member of the Canadian Psychoanalytic Society and the International Psychoanalytical Association since 2005. I will now leave you to enjoy Dr. Dabbagh's presentation. تفضل دكتور.
Thank you very much, Sarah, for this introduction, and welcome everybody. And I hope that you find this lecture useful. So basically what I would like to talk about is essentially the way we think about diagnosis in mental health. And hopefully for some of you, you might find this useful in modifying the way you look at and approach some of the issues that we face on a daily basis. Okay. So what I'd like to talk about first is category errors. Category errors are basically a logical fallacy. It's a semantic or ontological error. Semantic, for those who may not be aware of the meaning of the term, essentially is the study of the nature and meaning of words. Ontology is the branch of philosophy that studies the nature of things and how we get to know the nature of things. So it's a semantic or ontological error in which things belonging to a particular category are presented as if they belong to a different category, or they're ascribed a property that they could not possibly have. Essentially, calling an apple an orange is a straightforward, category error, but that's too obvious. Where the issue is, really felt in everyday life, is when it's not so obvious. So in order to be able to show that a category error has been committed, you really have to have an adequate understanding of what the phenomenon is. And once you have that understanding, it becomes automatically clear to you that whatever the claim was could not possibly be true. That's how you end up knowing that it's the category error. And the concept was first introduced actually about the mind, which is interesting. This was back in, I think it was 1946. Gilbert Ryle argued that we can't treat the mind as an object that's made of some sort of substance, because in his view, you cannot make predictions of substance that are meaningful for something that is essentially a collection of dispositions and capacities, which is the mind, right? It's our tendencies and our abilities. So that was how he introduced the concept of category, and he gave several examples. for it. But generally speaking, this logical fallacy involves, in most cases, confusing the properties of the whole with the properties of the part, meaning that, or the other way around. So, meaning that you think that the part has the properties of the whole, or you think that the properties of the whole are the same as the properties of the part. So that's why some people divide category errors into two classes. Fallacy of composition, which is when you assume that the whole has the properties of the part, or fallacy of division, which is when you assume that the part has the properties of the whole. So let's look at some straightforward examples of how we make these category errors. If the following claim is made, it's a category error. Because large objects are made of atoms, then large objects have the properties of atoms. And atoms have the properties of large objects. Those are two category errors there, right? If you understand what atoms are, then you will automatically realize that this is a logical error. You can also make this error, which by stating that birds cannot fly. And the reason why they cannot fly is because feathers can't fly, or visceral organs can't fly, or bones or muscles can't fly. So here you're assuming that the birds, the whole, have the properties of the parts, the feathers. That again gives you a category error. And this is actually important because if you if you think about the implications of this kind of logical error, you'll find that a lot of our reductionist way of thinking in science tends to rely on trying to figure out the properties of smaller parts rather than wholes. And this is essentially what reductionism is. You keep going to smaller and smaller scales. And when you find out that those small scale studies do not actually explain how the whole functions, you find yourself stumped. And a lot of brain function works this way. We know how neurons work. We know how genes are transcribed and producing the proteins that result in the specific functions of the neuron. We know how neuronal circuits work. We know what the small level of complexity function of each part of the brain, each organelle within the brain. But we don't know how the brain generates the mind. So this is an example of how simply looking at parts does not give you a sense of what the whole does. A more straightforward one, if you're saying that the Dammam is humid, and then conclude that as a result Saudi Arabia must be humid, then you're making a category error. That's a very straightforward one. Saying that apples are sweet because they are red. Now, there's no connection between the redness of the apple and how sweet they are. But this is the attribution of a property to redness that it could not possibly have. So that's a category error. A more subtle one, harder to point at, is saying that poverty is the reason why I never had enough money for my basic needs. Well, that is also a category error, because poverty is that you don't have enough money for basic needs. But what this statement does is attribute causation to poverty. So basically, it attributes causation to poverty for poverty, which obviously is a logical error. So those are the sorts of ways we make this kind of error all the time in general life. So it should, I hope, become easy for people to realize what sort of logical errors are being made on a regular basis in daily life. Now, that brings us to the end of the philosophy lesson component of this presentation. And now I'd like to move on to how this applies to us in health practitioners. So let's look at one example, fever. Let's suppose a patient presents with fever, okay? So what is your diagnosis? I would assume, I mean, although it's going to be hard to get immediate responses from the audience, but I would assume that nobody is going to venture a diagnosis because fever is usually a symptom of something else. So, and usually after exhaustive investigations, if we cannot find the source of the fever, we'll call it fever of unknown origin, which that title essentially means that there is an origin, we just don't know what it is. But we are not able to give a diagnosis simply by indicating that a person has fever. So it cannot be categorized as a diagnosis. You cannot say that fever is the diagnosis in the vast majority of cases. So if it's not, then what do we need to do? Well, the answer is we need to go and try and find out why this person has a fever. Now, this might seem like a cartoonish way of presenting, a very straightforward clinical problem. But you're going to see how this is relevant to this discussion. So, a diagnosis here, if we are able to find it, aims to explain why we have a person who has fever. It does not explain, fever itself does not explain the existence of fever. Fever cannot explain itself. So I hope that this point is kind of clear to people. Yeah? Once you have this in mind, I think it will make the rest of this talk easier to understand. How is this relevant? Well, diagnosis could also be a category error. In the previous example, if we had decided to say that fever is the diagnosis, then that is a category error, right? But let's look first at what diagnosis is. So if you're not familiar with what the word etymology means, etymology is the study of the origins and history of words, right? So just like in Arabic, we have words have roots, and we can trace the construction of the word to the roots, and we know the history of its usage and so on. Etymology is the equivalent of that in English. So when you look at what diagnosis means based on its etymology, it's scientific discrimination, particularly in pathology. Now, the first usage of it was for pathology, for medical reasons, but it then got generalized to mean discrimination of the knowing the reason behind or the cause of any issue that we face in life, discriminating it from other things. So it is basically that if you apply that concept to pathology, it means the recognition of disease from its symptoms, which is what you know from medical school or from whatever health profession you come from. The origin of the word is to distinguish, to discern things from one another. That's Gaia. And then gnosis or gnosis is to know. So it's basically a word that is used to decide what it is that we are facing based on knowledge of it and being able to discriminate it from other things. Right. The most common definition for it currently is basically the identification of the nature and cause of a certain phenomenon. And this is a more general definition than for just medical purposes. So again here, a diagnosis is supposed to refer to the nature and cause of a phenomenon. That's not how it always was used, the word, in the medical field. So it was originally simply a label given to a cluster of observed symptoms or to an injury of some sort. And in that original usage, the label, being a label of something that is observed, that is kind of related to disease or injury, it did not have an inherent property of explaining the cause of the disease. The label did not have that. And there were theories that explained the illness. I mean, some of you might remember reading about the humors and, bile and blood and water and so on. And throughout history, there were several stages where medicine developed various theories to explain why illness happens. So the way it worked was that a person would have a disease called X, some kind of diagnostic label, and then the physicians would suggest the cause based on the theory that they have. So the disease itself, calling it whatever it was called, the label did not explain the disease. It's the theory that explained the disease. But that was very early in the history of medicine, and in the last couple of centuries, there's been a great deal of development in medicine, and things began to change, especially in the 20th century. The progress of science has resulted in the diagnoses referring directly or indirectly to the underlying causes of the diseases. So if I call, even though I'm using a label that might be descriptive in nature, because that's how it originally was proposed, or might be just the name of a person, the person who discovered this syndrome, right? But once you use that label, there is an inference of the underlying causation. And that has resulted from the growth of medical sciences, allowing us to very specifically pinpoint etiologies of different conditions. So Nowadays, if I say, if I utter the word that is a diagnosis, the listener will think of the underlying etiology, particularly if they're in the field, they're in the medical field. So for instance, type 1 diabetes mellitus, even though the word diabetes mellitus means sweet urine, we are not thinking of sweet urine when we hear the word type 1 diabetes mellitus. We are thinking of an autoimmune condition that has resulted from cross immunity between a particular virus and the Langerhans cells in the pancreas. It starts at an early age and leads to complete insulin dependence. What I just said, for anybody who went to medical school, will come automatically to mind if one says type 1 diabetes mellitus. So the diagnosis carries within it the etiological inference. When we say pneumonia, we think of a microbial infection of the lungs. But the word pneumonia does not mean that. The word pneumonia means lung disease. That's its etymology. But lung disease could be many other things, right? However, we are specifically now referring to a microbial infection of the lungs. Same thing with sickle cell disease. It's a very descriptive term. It describes how these red blood cells look like. And even though it's descriptive, we fully understand the underlying etiology, a very specific autosomal recessive disease that affects how hemoglobin is made, and it results in these sickle cells. So the diagnostic terms carry within them an inference of the underlying etiology. And as a result of this, the entire medical field, and not just the medical field, the entire healthcare field has now become accustomed to attributing etiology or inferring etiology to diagnoses. And that's when a category error can happen. If, in fact, the label does not, in actual reality, explain the disease, then you are committing a category error with a diagnosis. So, this is the kind of logical fallacy. It still happens in some areas in medicine, right? Much less frequently than, say, in psychiatry, but it does happen in some aspects. But the majority of conditions in general medicine have kind of found a way around this issue. Obviously, diagnosis is critically important. Initially, before we were able to figure out what the underlying etiology of disease was, we did the sort of studies that we do now in psychiatry. We kind of find effective treatments that we associate with the diagnosis. So if a group of people have a diagnosis and we try a certain treatment and it works for a majority of them, or it results in a positive change that I can demonstrate in experimental research, that association of the result of the treatment with the diagnosis allows me to use that treatment for this particular diagnosis. But medicine has moved away from this for a large percentage of medical conditions, if probably the majority by now. And the way treatments are developed is to basically target etiological factors. And now you know ahead of time that you have a pretty good chance of being effective because you are targeting the etiology. And in most cases, if you're not effective, then you're going to find out more about the etiology that maybe you didn't know before. And if you are effective, but the medication is not a good choice, it's because side effects are probably not tolerable or toxic or whatever. But people now develop treatments with a laser focus on etiology. So it's not simply associating diagnoses with outcomes of treatments. So in this case, inferring etiology from the diagnosis, when that's what we are doing, does not constitute a category error, right? It essentially, diagnosis here stands for the underlying etiology. The two things are immediately related. So, which brings us to a discussion about, I mean, this is a little bit of a tangent, but you'll see why it's important, about evidence-based medicine and precision medicine. Even with the major advancements in medicine, treatment effects are very often heterogeneous. So if you have a group of people with streptococcal pneumonia, and you give them, penicillin, and they all have an organism that's sensitive to penicillin, you're not going to get 100% response. And there is some degree of variability in the response, even though you have covered all of your bases when it comes to etiology. For conditions where etiology is not that clear or complex, and you don't have treatments that are laser focused on targeting etiology, then the heterogeneity is, as would be expected, larger. So an assumption that a treatment works in evidence-based medicine usually comes from analysis of group means, right? So essentially a group receives an active treatment, a group receives placebo or another treatment with which we are trying to have a comparison. And then the mean response of each group is compared to the other. So if the mean response in one group is better than the mean response of the other, then you can say, well, that group had a superior intervention. But mean responses carry within them variability, which is why you have standard deviations and standard errors in these studies that look at the variation in the response of each subject within these studies. And the variation can actually be quite wide within each group, with some subjects completely not responding, whereas you have some subjects that are responding beautifully. And you may have outliers with extremes of response, whether on the positive or the negative side. And because we have to have a deeper understanding of the etiology, in these, when we do have that, for the condition that's being studied using a randomized controlled trial, for instance, or a systemic review of randomized controlled trials, what you'll, if you have a clear understanding, like the example I gave you, streptococcal pneumonia, penicillin responsive, what you would end up attributing the heterogeneity to is to individual factors, because you have essentially addressed the etiology. So what else is possible as an explanation for this heterogeneity other than individual factors? But because those individual factors do exist, that has resulted in the development of precision medicine. Individual factors are actually quite likely in almost every kind of study that you look at, and to be independent, and they are independent, often completely independent from the etiology of the disease. Although in some cases they interact with the etiology of the disease, and that interaction will result in a modification of the outcome. But that interaction is often relatively easy to measure and to understand and to pinpoint biologically, molecularly, a genetic variant of some sort, for instance, differences in liver enzymes, and so on. So it is quite possible to figure out what those individual variables are as a result of that. And because you are able to explain these individual factors at a molecular level, we have precision medicine, which aims to solve this issue of heterogeneity of response to evidence-based medicine-supported treatments, and then develop more individually targeted treatments that take into account each individual's unique factors that may affect the outcome of treatment. This is the reason why precision medicine is taking over, right? And it's not at this point possible for precision medicine to completely supplant evidence-based medicine. It requires evidence-based medicine. You need treatments that have been shown to be effective at a group level in order to be able to figure out what the individual variation is and how much of it exists, and then figure out what causes those individual variations, and then begin to custom tailor the treatment that individuals with very specific factors require. So, how does any of that apply to psychiatry? And I'm guessing the reason why most of you are here is to hear the answer to this question, and allow me to try to show you how we fall in so many categorical errors in psychiatry. Psychiatric diagnosis in its current form, we rely heavily on the DSM and the ICD, is basically the observation that certain symptoms tend to cluster together. And when they do, they result in dysfunction, what we call a disorder, which is, not that different from what syndromes are in general medicine, right? But the difference is, with syndromes in general medicine, we have been, over the past century and a half, we have been able to find out what the underlying tissue pathology involved that explains these syndromes for a large percentage of them. We have not been able to do so in psychiatry. We don't have the access to that yet in psychiatry for the vast majority of psychiatric diagnoses. Not all of them, but the vast majority of them. So let me give you the implication of this in a couple of simplifications. The patient comes to you and says, I feel depressed. You notice that the patient has the cluster of symptoms that is related to that. And you have observed these symptoms. You've identified the syndrome, which is called major depressive disorder. And you tell the patient you have depression. The diagnosis was made. So the patient literally tells you, I'm depressed, and you tell them you have depression. I know this is a simplification, right? But hear me out. A similar one. Patient comes to you saying that they are anxious. You observe the syndrome of anxiety, and you tell them that they have generalized anxiety. What are we doing in these examples? When the patient presents with depressive symptoms, the question is, what is the diagnosis? Now, remember, just juxtapose this with the example of fever that I gave earlier. Can you categorize depression as an explanatory diagnosis? And if the answer is no, then what do we need to do? We need to find out why a person is depressed. So a diagnosis here aims to explain the existence of depression. Depression itself does not explain the existence of depression. Saying that a person has major depressive disorder does not explain that they have depression. This is the category error that we commit almost on a daily basis in psychiatry. So why do people come to us complaining of depression or anxiety or whatever else they want to complain about? What is it that brings them to us? What brings them to us is that their life is miserable, that their relationships are breaking up, they're not working, they're causing them to suffer. They're not able to work, they're not able to study. Their family is a source of distress, or that they've experienced trauma or major life events that are destructive to their lives. I mean, there could also be a longer list, but none of what I just listed here, which are the reasons why the person is walking through the clinic's door, is a diagnosis. None of this is a diagnosis. These are reasons for why we find out that they have major depressive disorder. So psychiatric diagnosis, essentially a set of criteria, diagnostic labels and diagnostic groups that are based on particular diagnostic systems that change from one edition of that system to the next. There is progressive expansion in diagnostic umbrellas, progressive increase in the number of diagnosable conditions. There were probably in the late 19th century 5 diagnosable conditions. And now you have over 300, and if you count all the branches of each of the diagnoses, you have close to 700 in the DSM-5. There's actually a progressive move away from underlying etiology in defining the diagnoses. The way some of the terminology changed from one edition of the DSM to the next was almost intentionally to eliminate inference to underlying etiology, right? And diagnoses range very widely with respect to validity of symptomatic clustering. So if I take a condition and just look at how often do the specific criteria of that condition actually cluster together in the general population, there's a very large variability between different conditions in the degree to which these symptoms cluster, their own criteria cluster. And then you take the same condition and have 100 different clinicians diagnose that condition, and you'll find that the inter-rater reliability varies widely as well between different diagnoses. And some of the most common diagnoses have the lowest inter-rater reliability and the lowest level of validity of symptomatic clustering. We've already talked about one of them, major depressive disorder. So, with few exceptions, there's no assumption of a unique explanatory underlying tissue pathology in psychiatric diagnoses. DSM-4 included a condition that was part of the group called pervasive developmental disorders, Rett's disease. Well, Rett's disease has a unique explanatory underlying tissue pathology. Well, guess what the DSM-5 did? It removed it. Subsumed the presentation under autism spectrum disorder. So, I mean, we have to understand that our diagnoses do not at all, with very few exceptions, refer to underlying etiology. Comorbidity in psychiatry is the rule. It is not the exception. Finding a patient that has only one diagnosis can actually be a very difficult task. Somehow, pharmaceutical industries are very good at doing that, because when they enroll subjects into their clinical trials, they find pure patients, which we rarely see in clinical practice. There's a concept called heterotopic continuity. There is there's a lot of patients that if you are able to follow them over time, and we see that a great deal in child and adolescent psychiatry, but it is also true of adult psychiatry. If you follow them over time, their disorders transition from one diagnosis to another. The most common type of this is people who transition from having bipolar disorder to schizoaffective disorder, or from schizoaffective disorder to schizophrenia, or bipolar to schizophrenia. This is very common. Disorders have several different developmental trajectories for different subgroups of patients, and that is only in the beginning of, we are only in the beginning of understanding these trajectories, because these require very long-term studies and large sample sizes that you follow during that long-term study. But we're finding very different trajectories, even though they have the same diagnosis. Heterogeneity of symptom presentation is actually the rule rather than the exception in psychiatry. Furthermore, symptom definition is often problematic. You know, when we say that a person has a delusion of inference, of reference, what exactly are we talking about? This is a very complex phenomenon. Not only are these complex thoughts that are interwoven, that are connected, it's a deep belief. It has direct implication on many functions of the person's life. If I wanted to pinpoint what part of the brain is doing this, I wouldn't be able to, because it involves large areas in the brain that each do different small functions. When we study the function of the brain, we actually are very reductionistic, and we try to choose cognitive functions that are very small, very well defined, in order to be able to find what part of the brain works on that function. So we're not able to find where a symptom starts in the brain, although we have some idea about large sections of the brain that being involved. And then because the symptom is so complex, clinicians will not always agree on what they are observing. So on top of this, all of these symptoms and disorders that we deal with in psychiatry have a very high level of interaction with environmental factors. There's an interaction with social factors, with economic factors, educational factors, etc. But not just an interaction of the developing individual who eventually manifests the disease. But once the disease is manifest, those symptoms, that dysfunction is going to interact with the environment, and the environment is going to interact with it. And then the treatments that are chosen for this individual will also interact with these factors. This level of complexity is so high that virtually no medical condition can claim to have this kind of complexity. And then there are random factors. Random factors that no matter how well you study a group and try to compare groups together, it doesn't matter how hard you look at all of the factors that you think might contribute to variability, there will be random factors. And as opposed to the factors that cause variability in general medicine, even when random, those may actually have some sort of biological, endophenotype that allows people to go and study it and eventually come up with a precision way of tackling the problem. It is not so in psychiatry, in most cases. I mean, they've tried, particularly in the field of pharmacogenomics, to figure out, whether particular genomic factors modify the response of the patients to particular treatments. And so far, that field has not been successful outside of very, very few, findings. And they've been at it for roughly 25 years. So is it any wonder then that heterogeneity of treatment effects in studies that use diagnoses for developing evidence-based medicine supported treatments in psychiatry is very, very high? It's not a wonder. It is, and we should expect it. It is expected, and we should expect it. So an example of poor logic is when we are asked about the reason for the patient's tragic sadness and isolation from society, our response would be, well, they suffer from depressive disorder. Well, that's not the reason. That is simply the label that we attached to that kind of clinical presentation. And if we think it's the reason, then we have fallen in the trap of a category error. Committing this error will entail that we do not take the actual causes into account. This is actually what happens clinically, daily, clinicians will simply focus on the diagnosis and more often than not, forget what has led to having this diagnosis. And therefore, their treatments will not be based on the uniqueness of the patient's condition. So what is it going to be based on? It's going to be based on evidence-based medicine results. We have a systemic review of clinical trials using a particular antidepressant, and it shows that, well, this antidepressant produces better results than placebo in a statistically significant manner. We are not really addressing this unique individual who walked through those doors and told us about his suffering. But what we are doing is saying because he has depression, then the treatment is sertraline. So treatment plans based on what has been found statistically in medical research on large groups of patients who met descriptive diagnostic criteria, but did not share the underlying causes. We make those decisions based on that because the possibility of benefit, basically the statistical possibility of benefit, is a little bit more than no treatment or placebo. This is no longer the way we make decisions in a large percentage of medical conditions. But it is the way we make decisions for most psychiatric disorders. So what is the solution then? Can we use precision medicine instead? Well, studying the underlying biological factors still depends on phenotypic diagnosis. That is the case in general medicine. It's not different. You still have to have the phenotypic presentation. Otherwise, you're simply not going to recognize the existence of the condition. And given that phenotypic diagnoses produce very high heterogeneity and comorbidity and heterotypic continuity in psychiatry, it would be understandable to find few, if any at all, highly specific molecular markers for disorders in psychiatry. So what we do end up finding is genetic risk factors that contribute a very small, tiny contribution to the variance of the disease, the disorder. If you look at an example such as schizophrenia, there are hundreds of molecular findings that were statistically associated with schizophrenia, hundreds. About 110 or so have been associated with a relatively measurable portion of the variance. Each very, very small portion of the variance. All 110 together contribute probably less than 25% of the overall variance. How many markers do we need to be able to explain the condition of one person? It really does not look like it is likely that we are going to be able to do that. We look at conditions that have extremely high heritability, such as autism, right, where heritability ranges from 70 to 90%. Heritability means the likelihood that identical twins will show the same condition, right? It's very high. And yet, we have over 400 genetic findings that are associated with autism. And all 400 put together explain something close to 38% of the variance. So it's very understandable because autism and schizophrenia and most other conditions are essentially syndromes that are based on observable likely to cluster together symptoms that are highly variable. So we are not really referring to a very clear phenotype to begin with. If we rely on precision medicine, we are not going to be able, at this point in the development of the science, to deal with any psychiatric disorders. So, having said that, someone in the audience might understand what I just said, that biology doesn't matter. But of course it does. It would be another kind of category error to say that it is biological, but it also is a category error to say that it's not biological. We know that the brain is part of anything that the mind produces. So biology is definitely involved. But attributing it entirely to biology without taking into account the subjective reality that patients experience. Some people who make this argument will say, well, that subjective reality can be explained biologically. Well, if we are able to do that, we would have done that a long time ago. We haven't. Maybe one day we will, but at this point we can't. So subjectivity is still not fully explained biologically. So we cannot throw that out and say that it's entirely biological. But it must be biological as well. So both statements, when they are exclusive, are categorically wrong. So what do we do? We need to custom tailor treatment that suits the unique individual that we are treating. And in order to do that, we need we can't be distracted by our diagnostic labels. That means we must at least partially change the way we think about treatment. Now, diagnostic labels are still important because, as I mentioned earlier in the talk, when we study treatment, we study the association of treatment outcomes with particular diagnoses. So that is knowledge that is helpful, but it's helpful at group level for pure patients. It may or may not be helpful for the individual that we are treating in the clinic. So evidence-based medicine needs to be taken with a grain of salt. It is useful as a framework that supports the decision making because it gives us some information that is not, our imagination. It's not our wild guesses. It gives us some information that is derived from data, which is itself derived from patients. And it helps us at least narrow the field of the treatment options a little bit. But in addition to all of the above discussed issues, there are really unique challenges to evidence-based medicine in psychiatry in particular. And I'll give you some examples. The placebo effect. Back in the 70s and 80s, there were no selective serotonin reuptake inhibitors yet. And the predominant antidepressant treatment was tricyclic antidepressants. It's a group of antidepressants that we refer to as tricyclics. Well, there were several studies that were done with tricyclic antidepressants on children. adolescents experiencing depression. And the results were quite astonishing. These were placebo-controlled trials, and more than 75% of the subjects improved. But that was also the percentage that improved in placebo, in the placebo group. So we could not say that tricyclics were statistically superior to placebo, but the placebo effect was enormous. You essentially cured a large percentage of patients with placebo. There are a lot of examples of this in psychiatry. One of the issues in psychiatry, and this is why pharmaceutical companies are very good at selecting really pure patients, is that the placebo effect, which, by the way, includes, among many things, the therapeutic relationship with the clinician who is prescribing the placebo. The placebo effects are so huge that they would like to find a group of subjects where they can demonstrate a difference between placebo and the active compound that they're studying. So placebo trials in psychiatry, placebo-controlled trials in psychiatry generally produce very small effect sizes, because the separation between the effect of the active compound and placebo is not huge. But if they can show that it's statistically significant, then they have a winner. But the effect sizes are relatively small. There were many systematic trials, for instance, on antidepressants with depression, and the effect sizes for depression are not that impressive. They are there. They're very important. And if you add that effect size to the placebo effect of the medication, you have a large response, which is what we see clinically. While this does not detract from the usefulness of these medications, it has to mean something. We have to try to understand what this means. And then you have psychotherapy research. When clinical trials are done in psychotherapy research, a really unusual thing happens. Psychotherapy researchers have decided, most of them, that they're going to apply the same model that we use for medications, the controlled clinical trials. Randomized controlled trials for medications, because they are medications, because they are things that we give patients to ingest, are fairly easy to control. I mean, they have some challenges, but there are ways to control for those challenges as much as possible. You are trying to make sure that every aspect of the intervention and the placebo look exactly and taste exactly the same. The clinician making the prescription is doing the exact same process. The clinician thinks that they are that they're prescribing something that has a 50% chance of being the active compound and a 50% chance of being placebo. They don't know. The patient thinks that what they are taking has a 50% chance of being a placebo and a 50% chance of being the active compound. They don't know either. There are issues related to that because side effects are a little bit more likely with active compounds. So patients begin to have an ability to guess and so on. But the reality is that you're trying very hard to eliminate the differences between the two groups and limit it to only the chemical compound that they are ingesting. That's not what clinical trials in psychotherapy do. Clinical trials in psychotherapy, the vast majority of them compare doing something with doing nothing. Now, if you take anybody and do something with them, you have a very good chance that you're going to see some change. And it doesn't matter what that something is. You're going to see some change, positive or negative, but you're going to see some change. And if what you're doing is supposedly helpful, then you're more likely to see some positive change. A clinical trial in psychotherapy that does not show superiority to a wait list is really, really rare. If you were to go and find a negative clinical trial of that nature, please let me know, because they are very, very hard to find. But negative clinical trials for medications are not hard to find. The other thing is that psychotherapy assumes that by manualizing the treatment, you are basically giving the same treatment to different subjects within the trial. Not only is that not true, meaning that it is not accurate. I mean, there is a large degree of similarity between the treatments provided to subjects within a manualized protocol. There is a large degree of similarity if the therapists adhere to the manual, but they're not identical. There is a relationship that develops between the patient and the therapist, and there are patient factors and therapist factors that change the nature of that relationship. And it is the nature of the relationship that has the highest correlation to the outcome of any treatment in psychotherapy. So it is not entirely accurate. But furthermore, and this is where the rub is, the less the therapist adheres to the manual, the better the outcome. And there's a lot of research to show this. So in other words, we are not actually supposed to provide the same treatment, which makes it very difficult to use assumptions that are based on uniformity of treatment the way we do in clinical trials for medications. And lastly, psychotherapy research has a very problematic history, which is that it does not study psychotherapy the way it is provided in real practice, in the practices that lead to good outcomes. It studies psychotherapy in the most convenient way to study them. So what a therapist is likely to, what a therapy researcher is likely to do is to try and design a very short-term psychotherapy trial, because then A, it's not going to be expensive, B, it's going to be easier to complete the study, and C, it would be nice if I can tell people that a short-term trial works. And if you design the study that way, you end up, because you're comparing to nothing, you are going to end up finding good results. And when you find the good results, you basically tell people that short-term therapy works. And I'm not saying that it doesn't work, but that's not how psychotherapy that is helpful to people actually works in real life. What in fact has happened is that there were consumer-based research projects that looked at people receiving psychotherapy in the real world, not within clinical trials. And they found that it takes 6 months for 50% of the population to find that therapy helped them. They found that the average high satisfaction therapy was 40 sessions in real life. That's the average. So again, it does not actually reflect the reality of clinical practice. So, but yet, the published studies on psychotherapy, which is the evidence base that we have, tell us that, you know, this is what works. It is entirely based on several false premises. And therefore, we need to be very, very critical when we look at that research literature. Okay, so lastly, I know I've been very negative so far, so I'm hoping that we can move into a little bit more of the solution side of this talk. After this, after this slide, we are not able to predict outcomes based on the way we understand mental illness at present. We are not able to even predict outcomes based on the risk factors that we know of when we address this at group level. There was a large study that was published 2 years ago in the Proceedings of the National Academy of Sciences, which is one of the highest impact journals worldwide, that looked at longitudinally looked at social determinants of health in children and youth, and it looked at 5 waves up until the age of 15, and developed a competition with 160 groups to use AI, machine learning models to use all of the factors that they put together, which was an enormous amount of data, to try and predict the outcomes, and they generally speaking, were not able to. Social determinants at group level cannot help us. So what I'm trying to say is that ultimately, the way we need to think about how to manage mental illness is to think about the individual and to think uniquely about the individual. And that is the solution that I'm going to be proposing. Personalizing mental health. And the way to do that, the first step in doing that, is case formulation. A lot of you know what case formulation is. And I know that people study very specific ways of doing case formulations. I'm going to share with you a common example that is taught to medical students and junior psychiatry residents. But case formulations are not in practice being used often. They are very rarely used. And when they are used, they're not used effectively. They're not used in a manner that actually helps the clinician custom tailor the treatment to the person in front of them. So when I say case formulation, what comes to the mind of many medical students and early residency psychiatrists is this grid, the biopsychosocial formulation grid. Based on taking the concept of biopsychosocial and breaking it down to biological, psychological, and social, and then looking at what the predisposing, precipitating, perpetuating, and protective factors are. This is a grid that is useful as far as it allows a person to categorize different elements of the clinical presentation, and perhaps helps them not miss some aspects of the clinical presentation. You know, if they have this in mind, maybe they forgot to look at what protective factors exist, and they'll ask questions about that and get that information. So it could be helpful in that regard. By and large, this is not that helpful. It is not easy to use a grid like this and generate a meaningful treatment plan. I'm not saying it's impossible. It's just not easy. It's not straightforward. It does not lend itself to helping the clinician do that. So I'm not saying throw it away the way I crumbled that slide, but you know, don't give it too much weight. How do you develop a real formulation? I'm not going to really be able to explain that to you today, because that's another talk. That's probably a course that could take 2 days. But in order for a formulation to be helpful, what it needs to be accurately reflecting both the subjective and the objective realities of the patient as much as is possible. So the subjective reality of the patient gets neglected in most formulations that I've seen people come up with. And what do I mean by subjective reality? When a patient talks about hearing voices telling him that you know, a person is against them, that experience itself is, while it is a hallucination, but it's not just a hallucination. It's a hallucination that generates fear in the subject. The patient is afraid. And if they are living in that fear, can you imagine what living in that kind of fear might be like? That subjective reality is missed when we are assessing psychosis. Commonly, we focus on, okay, we have this symptom, check. We have that other symptom, check, and so on. Subjective reality is absolutely necessary in order for you to be able to develop a good formulation. Formulation development is a skill that depends on a deep understanding, not just of the patient's symptoms or the patient's level of dysfunction, but the patient's self. How did this self develop? How does this person interact with others? How does this person develop relationships? What was the trajectory of his development? The accumulation of experiences that have shaped his personality. It is not static. You may develop a formulation today and review it with every visit that you see, in which you see the patient. It has to constantly match the experience of the patient, the depth of understanding that you have of the patient, which is supposed to grow with time. Often our depth of understanding shrinks with time in the way we practice psychiatry these days. But we need to grow our understanding over time of the patient. And because the patient's experience also changes, particularly once you introduce treatment, then you may need to modify your formulation. What applied initially may not apply now. So a good formulation, if you're able to develop one, is actually correlated with a better outcome. you're going to get good outcome if you have a good formulation, whether you are treating with medication, with psychotherapy, with psychosocial interventions, uh, admitting a patient or seeing them outpatient, whatever it is that you're doing, developing a good formulation is going to likely increase your chances of getting a better outcome with the patient. So the general weakness in understanding how the self develops in practitioners in the field makes it hard for them to develop a deep understanding of the patient. So you end up having weak formulations. And if you're psychoanalytically inclined, psychodynamically inclined, and you're able to develop a better understanding of the development of this individual, you may be able to develop a good formulation. Now, you don't necessarily have to be psychoanalytically inclined, but you have to have a model or a set of models in your mind that help you develop how this person became the person that they are. How did Fulan become Fulan? And then you are able to appreciate their reality. And being able to develop that good formulation will allow for a greater level of mentalization and empathy. I don't know if everybody here knows what the word mentalization means, but mentalization essentially means the ability to recognize that the other person has a mind, being able to, with some level of accuracy, guess the content of the mind of the other, being able with some level of accuracy, I mean, it's never perfectly accurate, obviously, with some level of accuracy, being able to assess what the person feels and relate all of that to one's own mind, know that how those mental contents relate to our own mental contents. So be aware of our own mind and what's in it at the time I am connecting to the mind of another person. This process is critical, and I mean, a component of it which most people know of is empathy. But we all do a degree of mentalization, some degree of mentalization of others. So if you develop a good formulation, you're going to be better able to mentalize and empathize. And it will directly reflect on the quality of the therapeutic relationship, which relies on the development of that mentalization and empathy. It's not likely that you can form a therapeutic relationship with someone you cannot mentalize. So why am I talking about the therapeutic relationship here when we were talking about diagnostic labels as category errors? And well, it's because the therapeutic relationship is the most important factor in the management of any mental disorder. And if you're going to make errors in understanding the patient based on that category error that I spent so much time explaining earlier, then you're going to be way off the mark in mentalizing and understanding the patient. And if you are, then you're probably not going to be able to develop a good therapeutic relationship with this patient, which means that the most important factor in the management of this patient is not with you. So the therapeutic relationship explains a large part of the placebo effect. The therapeutic relationship is, for the most part, the factor that determines adherence to treatment. The therapeutic relationship is, in fact, components of it are the mode of action in psychotherapy. It's not the techniques used. It's not the school of thought that you're following. The mode of action in psychotherapy that has the highest explanatory value for outcomes of psychotherapy is the quality of the therapeutic relationship. And in reality, without them telling you, that's what a lot of people, perhaps most people, want when they come to see you in the clinic. They want to develop this relationship with a clinician that is going to help them. So, it is unique. It is in each doctor-patient relationship, each therapist-patient relationship, each dyad is very different than any other dyad. I am not the same therapist with any of my patients. And that dyad, me and my patient, is different, unique, and completely unrelated to those other dyads. In other words, highly individualized, personalized, based on the uniqueness of the patient. Begins with a formulation that reflects a deep level of understanding of the patient's self and its relations to the problems of the patient. And it is co-constructed. No relationship is built by one person. It's based on both people. They both contribute to it. It's not symmetrical. There's a power gradient. The therapist is the expert. The patient is the one seeking help. But they both contribute to building this relationship. How does it work? Well, it starts by listening deeply when you're assessing a patient. If you're going to try and complete a checklist, you're not very likely to be listening deeply. It would be helpful to develop a psychodynamic sense of how this person became the person presenting to you and asking for help. If you're not familiar with psychodynamic thought and models, perhaps you have another model that you can use that helps you understand how this person developed and became this person. As this deep understanding or formulation develops, empathy, presence, mentalization become more possible and more accurate. And when that happens, the foundations for a meaningful therapeutic relationship, regardless of what the treatment modality is, are laid down. For those of you who are in psychiatry or medical field, there's actually a field of study called the psychodynamics of psychopharmacology. And you'll find books on that, textbooks on that. It does not matter what modality of treatment you're providing. The therapeutic relationship will definitely influence the outcome. So going back to the poor logic that I gave an example of earlier, how can someone who suffers feel that we understand them if we attribute depression to depression? A better logic would be to express to the patient a comprehensive understanding that links the causes and symptoms, and then the effects of those symptoms on the patient's life, and leads to the formation of a successful therapeutic relationship based on this understanding and empathy, and leading, hopefully, to radical change in the patient's life. The patient came telling you that their life is miserable, and hopefully you're going to help them make their life less miserable. So the take-home message is, don't focus only on diagnosis. Focus on the person. Listen deeply and mentalize, formulate, personalize the management, and focus on the therapeutic relationship. So with that, I'd like to start the discussion section of this talk. So for the moderators, Sarah, how do you want to manage this part of the evening?
Okay, thank you, Doctor, for this lecture. It has been very insightful and enlightening for all of us. We have some questions in the Q&A, and some have raised their hands. So would you like to read them and answer, or would you like me to read?
Perhaps you could choose. It's a little harder for me.
Okay. So there's a question that says, can you talk about the use of professional self-doubt to facilitate better outcomes?
Professional self-doubt, meaning that I mean, I'm not entirely sure what the person asking the question meant, but if I were to venture a guess, that the professional, the clinician who is involved in the care of the patient, is experiencing self-doubt about their approach to the treatment. Like everything, there is no right or wrong, black and white kind of distinction here. Self-doubt in its extreme form is probably unhelpful to the clinician in dealing with a patient. The lack of self-doubt altogether means that this clinician is so sure of their understanding of the situation that they might become blind to many aspects of the patient and follow their own agenda rather than an agenda that's driven by the personal needs and situations of the patient. And that would probably be just as bad. The clinician has to constantly reserve in the back of their mind some likelihood that their understanding of the patient is inaccurate, that there's something that might end up being known later that changes their formulation or understanding of the patient, that they may have made the wrong choices in their management options. That small amount of doubt is necessary for the clinician to remain agile and vigilant to the needs of the patient. I hope that answers the question.
There's another question that says, how to help the patient who doesn't have insight?
The patient that doesn't have insight has a subjective reality. The patient that does not have insight is suffering. Are you able to connect to that suffering? Psychotic patients will still be able, well, not all of them, but the majority of them will still be able to recognize that the clinician in front of them has been in touch with what they feel. Are you able to mentalize what they are going through? And if you are, that is going to dramatically change how the course of treatment of this patient is going to end up being. And I can tell you that from experience. And I can tell you also from experience how not doing this was detrimental to the care of the patient. So insight or no insight, I don't think that matters in most cases.
There's another question. Can you recommend a practical book that helps establish therapeutic relationships with our patients?
Ah, okay. Now that is difficult. Um, I don't really read books about formulations. So there may be others in the audience who know specific books about formulations. Um, my approach to developing a formulation is having adequate basic knowledge in all aspects of a condition. You have to have as much knowledge as you can about the underlying biology that might be involved in a disorder. You have to have a basic understanding of the biological state of the patient. You have to have an adequate understanding of the social circumstances that brought this patient to you, the social circumstances that the patient grew up in, that within which the patient's personality developed. And you have to develop an understanding of the internal subjective experiences of this patient. And then you have to have a psychological model that allows you to put all of these things together. Whether you're using a schema-based cognitive approach, or you're using a psychodynamic approach, or whatever approach you're using, a systems theory approach, whatever, you need to have a way of putting it together so that it's a narrative that's understandable. It's not bits of data listed on a piece of paper. It's the story of a person and how this person became this person, and a story that allows you to understand and empathize with their suffering. That's how I approach formulation. I don't necessarily need to read a book about that. I need to read books about all of these different components of what ends up being part of a formulation.
There's another question that says, was there any studies showing a difference in the outcome for schizophrenia between biopsychosocial case conceptualization and real formulation? Can we use both type of formulation, or are they mutually exclusive?
Okay, so real formulation is not a term that is widely used, so there is no studies comparing it. When studies look at formulations, they look at formulations, and these formulations are usually biopsychosocial formulations using a grid model, right? Or biopsychosocial formulations using a specific theoretical framework. Okay, so they're not. There are no studies comparing what I refer to as the real formulation. And the real formulation is not a thing that you can generate with uniformity within a group in a research project. I refer to it as a real formulation simply because it reflects the clinician's understanding of the subjective reality of the patient on the one hand, and understanding of how the patient became this patient on the other. In general, studies that have looked at formulations, they have found them to be helpful in outcomes. They have not compared, to my knowledge, different modalities of developing formulations.
Another question says, is making a contact with the patient from his family, for example, if you went to therapy, you will get your allowance. Would it help?
Can you repeat that? I'm not entirely sure I understand the question.
Okay, so they're saying, is making contact with the patient, and
Yeah.
between parentheses from his family, for example, if you went to therapy, you will get your allowance. Like if the family
Allowance?
said that to the patient, I believe this is what they mean.
I still I still don't know what they mean. The family needs to
Like,
contact the therapist or the patient.
I'm not sure if Lujane, you would like to speak through the mic. Yeah.
Yes, hi, doctor. Thank you for this informative lecture. I wanted to ask if the family made a contract with the patient, like if saying if you went to the therapy, you will have your monthly allowance, and the patient was not insightful and was not motivated to with the treatment. Would the therapy session benefit him on the long run? I know it's a very subjective question, but just I would like to know your answer. Thank you.
I mean, are you asking whether therapy sessions with a patient who is not insightful and not adherent to treatment help the patient, or are you
Yes.
asking that the family needs to contact the patient? Those are two. I don't see the relation between these two parts of your question.
Yeah, it's the first part only.
Okay, so yes, and there are, while there are not a ton of studies on psychotherapy with patients that are psychotic, that lack insight, there are some, unfortunately, still using short-term therapies. However, there are a lot of case studies where therapists report on on single cases, showing that long-term therapy with patients that are schizophrenic or psychotic or poorly insightful or even having bipolar disorder and so on have over time helped them change their lives to the better. That may involve an improved adherence to treatment and so on. I'm just reflecting on the question that was asked earlier about books for formulation. There are books for psychoanalytic case formulation that I'm familiar with. If people are interested in that, the one that is most famous is the one that was written by Nancy McWilliams.
Someone from the audience also recommended the same book.
Oh, mashallah, tabarakallah. We have people that have, okay.
Okay,
Yeah.
so the next question is, can we have another talk on case formulation, focusing more on a practical approach for it?
Well, perhaps maybe we should have another talk.
Yeah,
I'll see if I can find the time for it. But that kind of talk is a lot harder to put together than this one, so it'll take more effort. And as I was saying earlier, it's not just an hour or 2 hours. It probably would be more like a course. So perhaps some people are able to give short talks on it, but if I imagine it, I imagine myself giving a course over a couple of days at least.
Someone is asking how to manage short time between patients list and the consideration of the discussed errors from therapist self-management.
You mean that the clinician doesn't have enough time to pay attention to these category errors? Is that the meaning of the question?
I believe so. Zainab, if you would like to speak through the mic.
Yes.
Yes, is my understanding correct? That the
Yes, doctor.
clinicians don't have time? I see. Honestly, I find that to be sad if it was truly the case, and I doubt that it is truly the case. If we are spending between 40 and 60 minutes assessing a patient, and we are doing so in a manner that allows us to connect with the mind of the patient, the subjective reality of the patient, it is not likely that we're going to have difficulty with this. If we, on the other hand, we feel so rushed and in need for our own purposes, not for the patient's welfare, but for our own purposes, in order to feel good about what we're doing, we need to complete the checklist as fast as possible, then we are going to miss the opportunity to connect more deeply with the patient.
Another question says, can years of psychotherapy be effective if the patient constantly refused to work on his childhood trauma?
Psychotherapy, just like any intervention, may or may not be effective. The idea that any intervention is always going to be effective, that's something that we have to revisit in our minds. So that's one thing. The other is that when psychotherapy is not effective, it does not mean that another psychotherapy or even the same kind of therapy but with a different therapist will not work. And lastly, and this is more of a psychoanalytic bent to psychotherapy, the resistance is the norm, not the exception. Meaning that patients come to you saying they want to change, but they don't want to change. They want to change without changing. And that is the real challenge in psychotherapy. And it doesn't necessarily show in clear, obvious ways. And it may take months or years before you find out that that is the case. But if you are vigilant about this, you'll see resistance from the get-go. So resistance is not an exception. When it does not exist, I often question myself, why am I not seeing any resistance?
Sami Sayed commented, please, we need more of this type of negative influence. And then asked, on a daily basis, I see on the trainees this type of repetitive cycle of seeking the symptoms to close the box of the diagnoses. What do you expect from the trainees to react or behave inside the social proof of our field? But the hammers above them if they try to change anything.
Thank you, Dr. Sami, for bringing up the issue of training. I was involved in training residents, and I know that what they have to go through. And unfortunately, a lot of the training, a large part of the training culture is focused on this, because the issues that I've mentioned are not limited to the trainees. The supervisors are doing this. The system of care is doing this. There is like a conveyor belt for patients, and it's like we're in a factory. We're not really providing care in the most human way that we should. And the reality is that trainees see that this is the model that they apprentice with, on the one hand, and B, this is what is expected of them when they are examined, when they are assessed by their supervisors. This is how they are graded. So simply demanding that trainees deal with this a little bit differently alone is not enough. It's important, but it's not enough. We need the supervisors to change the way they approach diagnosis. We need the system as well to improve in this area. So God help the trainees. Honestly, all I can say is that if a trainee feels that no matter what they do, they are required to follow a specific way of assessment, well, perhaps they should do that for that purpose. But learn how to assess patients in this more humane, real, connected manner, personalized manner, in order for them, when they become independent clinicians, to be able to practice good psychiatry. And perhaps then they can be part of the solution that changes the system.
Okay. I believe we have no further questions at this point.
Thank you. These are really wonderful questions.
We got one more. Away from the
Yeah.
clinic, should the knowledge, techniques, and skills of a psychotherapist be present with everybody around us?
Everybody around us. Well, every mental health clinician should have the knowledge, techniques, and skills of a psychotherapist. If you're a mental health professional and you have no skill or capacity to be therapeutic, you have a problem. Everyone around us is a little bit of a little bit too wide of an umbrella, but definitely mental health professionals should have psychotherapy skills.
Someone commented, therapeutic relationship is therapeutic to both the psychiatrist and the patient. Do you agree?
I absolutely agree. They're not equally therapeutic. The relationship is not symmetrical. But if you are doing psychotherapy in particular, I mean, the general practice of psychiatry is a little bit different. Or if you're a psychologist and your only involvement is a psychometric assessment, the interaction that you have with the patient adds to you as a person, but not as much as what it would if this was a psychotherapeutic relationship. And if it was a psychotherapeutic relationship, or even a psychiatric, psychopharmacological long-term relationship, this person becomes part of the object world of that you have in your mind. You have developed relationships with patients, and these relationships have an impact on you, on your personality, just as much as you have on theirs. You may have a larger effect on theirs, particularly in psychotherapy.
We have a question from Manar, if you would like to speak.
Hi, Sarah. Is it possible to add something here?
Yeah, go ahead.
Yeah, thank you, Dr. Yasser.
You're
Just
welcome.
one thing to think about actually after this talk is to think about, what is worse in terms of, diagnosing someone or giving someone the label and just convincing him that your problem is what is the obvious, is depression or anxiety or any of that. And there is nothing related to it. It's just the depression itself. So we're going to give you this medication and you're going to be okay. It's a matter of a course of a treatment. You're going to take it for a certain period of time and then you're going to be okay. The effect that is going to happen after that, when he realized later, no, it's not the case. And the time that he spent during the whole time just understanding it is depression, it's nothing else. It's even for us to think about it more, actually, the effect that is going to happen when we just start labeling people. And I don't know if is it leaving them alone is better than just bringing them and giving those labels and just sending home again.
Are you saying that would it be better not to tell them what the diagnostic label is? Is
Yeah,
that what you're trying?
yeah, I think stay at home maybe even better.
Stay at home better. Well, I cannot really agree with that. Even if a therapeutic relationship was not developed, even if people commit this category error, and based on the category error, they choose an evidence-based treatment that is designed to produce a better outcome in a group of pure patients compared with placebo, there's still a chance that that could be helpful. It may not be entirely a waste of time for either the patient or the clinician. It's just not a huge chance. Not only is it not a huge chance, the patient is likely to have great doubts about the opinion of the physician, the clinician here. If you go in to see a surgeon with abdominal pain and you leave the office thinking that I'm not sure this person understood what I went through, you're less likely to accept their recommendation for surgery. And the same applies in mental health. If the patient does not feel that you understand them, they are less likely to adhere to your management recommendations. They are more likely to keep shopping for a doctor that is going to understand them, or basically cater to them. I mean, because understanding doesn't necessarily mean catering to the patient and giving them what they demand. Understanding is understanding. So the likelihood that some of these negative outcomes is high, but I cannot exclude the possibility that some benefit could take place. So I would not go as far as you're suggesting, that just have them stay at home.
I'd just like to take a moment to remind everyone that the link for attendance is in the chat. We have a question. There is solace in knowing that there is a name and disease for the thing that they're going through, that many people suffer from a similar thing. Can labeling be therapeutic in this situation?
Well, there is a label. I mean, when you see a patient, there is always a label. You're going to give a diagnosis. And some people really have a high level of investment in having this label. For many, it gives them a way of externalizing their suffering. So there is this thing called depression, and that's to blame for my problems, right? For others, it helps put together disparate aspects of their experience. They may not know that depression is a cluster of symptoms that include anhedonia and loss of libido, as well as insomnia and suicidal ideation. And you explain to them that they're all part of the same syndrome. For some people, this label is helpful. For some people, a label can be helpful for them to actually get social support from social services, or get a day off of work, or convince an insurance company to pay for medication. Labels are useful. We unfortunately cannot do without them. And for some patients, they have a high level of investment in these labels. So they have a function for them. But if we assume that the label is the problem, then we are not going to properly help this patient. and that was the whole idea that I was trying to share with you today.
Someone is asking if you were requested to give a word to beginner psychologists. What would you say?
Beginner psychologists. Okay. Let me see. Beginner psychologists often means graduates of a bachelor program in psychology. Usually, not always, but that's usually what it means. And graduates of a bachelor degree in psychology will often have read a lot for 4 years and have had maybe 4 months of clinical exposure before they find a job in the field and begin to practice, or before they enter a graduate program. So there isn't a great deal of clinical exposure involved as soon as you graduate. Maybe over time you can accumulate clinical exposure. Clinical exposure is what really tweaks your ability to connect to people. You have to see more people, more sick people, all sorts of sick people, of all kinds, of all ages, of all disorders, as many of them as possible, under supervision with someone who knows what they're doing. In order for you to be able to have this experience of listening to the suffering of other people, figuring out what it's like. And then once you've done that adequately, you're going to find yourself more able to empathize and mentalize with patients, more able to understand them with a higher level of accuracy, more able to formulate cases. And whatever modality of treatment that you're being trained in or receiving training in, you're likely to be able to practice it more accurately, more helpfully for the patient.
What about recommendations for junior resident?
It's the same recommendation. The only difference is that a junior resident is going to be inundated with patients. They're going to be thrown in a sea of patients. And what junior residents will often find themselves doing is having to run from one patient to another. And when you're thinking about how am I going to get to the next patient in time, then your mind is not with your current patient. I don't envy you, and I don't think that it is going to be an easy task to try and acquire these skills early on when you are so busy. But over time, you're going to find that you will get a little bit more time with each patient, and you're going to be a little less rushed. And when you have those opportunities, these are golden opportunities. Do not squander them. They are gold.
We have one last question. Can a trained psychotherapy psychiatrist select or choose between patients in terms who's getting only medication prescription and who's getting also psychotherapy in addition to the medication?
Yes, absolutely. As a matter of fact, that is their role. Their role is to determine whether a patient needs psychotherapy alone, medication alone, or a combination of both. This is part and parcel of the role of the psychiatrist. And unfortunately, not many psychiatrists are able to provide the therapy themselves, but it would be great if they are. And if they are able to provide the therapy, what often happens is that there is a little bit of a bias toward the modality of therapy that they are trained in. And they may offer it too much or offer it to the inappropriate patient, or deprive patients from another modality that might be better suited for that specific patient. But those are mistakes that we always make. Psychiatrists make these mistakes, and psychologists make these mistakes. Differential therapeutics is a complex area that requires a lot of experience and training.
I think this concludes our questions. We don't have any more questions.
Okay. Well, thank you very much, everybody, for your attendance and your attention, and for tolerating a bit of a philosophy lesson at the beginning. And I'm hoping that this was helpful.
Can we go to the next one, please?
Okay.
Here we have a QR code for some mental health related resources from our campaign.
Do you want to go to the next one, or
Yes,
wait
please.
a bit? Okay.
And I'd also like to note that there's an app called Qaribun by the National Center for Mental Health Promotion, which offers psychiatric consultations by specialists in the field. It also has some informative resources about mental health. Okay.
Okay. Well, thank you very much for the invitation to give this talk, and I really appreciated the discussion. There were some really wonderful questions from the audience.
Thank you, Doctor. I would like to thank you on behalf of NEF's team for taking the time to be with us today. It was a great pleasure. And we'd also like to thank you for shedding light on such an important topic in mental health. And we hope to implement some of those insights in our everyday practice. I would also like to thank everyone for being with us today, and hope to see you all in our future events, inshallah.